Before we use a very broad brush, which we've been doing, to discuss multiple sclerosis, we've been able to type it and get subgroups and subtypes, right? There are different kinds of multiple sclerosis. You want to lead us through these things?
The major form of MS is relapsing. It's also called relapsing remitting. I don't like that because the disease does not remit. We don't have any good data. That's how 85 to 90% of MS will present, with a clinically isolated syndrome, which is the first attack. And you can grade that first attack as high probability of MS or not. Do they have lesions on the brain that are otherwise unexplained with their optic neuritis or transverse myelitis? So that's the major form of MS, relapsing MS, that presents with the first attack of CIS.
Is it relapsing, remitting? Is that what it's called?
No, I don't call it that. The National MS Society does. I don't like that. It's because it's inaccurate. The disease does not remit. We do not have data that MS remits. We shouldn't be calling it that. We should be changing the name.
You're going to see in the literature, you're going to see RRMS.
You win. It's relapsing remitting, but they're wrong. It's relapsing MS.
So we both win. How's that?
All right.
I love politics.
And then the other form of MS is progressive MS, slow worsening. We believe that represents the neurodegenerative phase. Primary progressive MS, slow worsening from onset, doesn't start with an attack. That's 10% to 15%. And then secondary progressive MS, which is a relapsing MS patient who then transitions to a progressive form of the disease, and that is secondary progressive.
And then there's this thing, CIS.
That's the first attack, clinically isolated syndrome. That can be the first relapse of relapsing MS.
Okay, so you get a symptom. Somebody calls this clinically isolated, and then where it goes from there determines the alphabet soup you apply to it later.
Correct. If they're CIS high risk, they basically have relapsing MS.
Okay, what about the educational and supportive systems? I mean, you establish this diagnosis. You say, you've got it, good luck, see you later, or you integrate them into some sort of support system.
This is an eminently treatable disease now. And we're saying the earlier you get on treatment, the better. That's why you want an early as possible accurate diagnosis in order to treat that patient and transform their life and change their future.
A treatable, you know, I never thought, because I didn't think, obviously, that we would be having this conversation where MS would be, someone would tell me it's an eminently treatable disease. Do you agree with it?
I would say it's an eminently manageable disease, because treatment would mean that we stop it in some patients. But I agree.
You've seen wonderful examples of the power of treatment.
Absolutely. So I fully agree with the fact that most appropriate intervention in a patient early on can change the trajectory, can also ultimately change how this person can continue to work or continue to do all the other things one wants to do in life. We are not good in fixing as neurologists.
No, that's tougher.
We are good in preventing things from happening.
That's why you want to start treatment early. I tell patients they can have a normal life.
You do?
Yes, I do.
And obviously you believe it.
And I believe that.
That's great.
Yeah.
But in order to get the proper treatment, and the way that the healthcare system is structured, you need to be able to parse this into, here it comes, ICD-10. Because ICD-10 has got to parse this out, make a diagnosis, put them in the correct payer group, and be sure that you guys are categorizing them properly so they get what they need. So do you use ICD-10? Do you triage based on ICD-10? Do you approve based on it?
Well, billing and coding reflects one code for MS, which is the G35 code. And I think that's also part of the issue. As MS is now evolving into perhaps multiple different diseases, how do we understand these? There's no biomarker that defines if you have relapse MS versus secondary or primary progressive. It's a journey. It's how patients present and how they evolve over time in terms of their level of disease activity and severity. So as such, if you will, from a coding perspective, and codes don't come from payers, by the way. The coding comes from the AMA, but we are at the mercy of one code. And so if a physician is calling and saying this patient has secondary, progressive, and perhaps it's by history, we have to take the physician's word. And also payers don't practice medicine, so we really have to rely on the clinician.
No, but the docs would argue with you. You're practicing medicine by denying us payment. But we'll get there later.
We're not, I mean, there has to be, usually we start, if it's a high-cost drug, and all these drugs are high cost, we have to start with what's the indication. And so, that's usually where the prior authorization begins.
I think you said something that is very important. It's the journey, and in a certain way, the terms secondary progressive multiple sclerosis. I mean, Pat, you pointed out there is primary progressive multiple sclerosis, never an attack progression from the beginning, and then there are the relapsing forms of multiple sclerosis. Obviously, the FDA has added a little bit to the different acronymic contributions in all of this, but these are the two groups but we don't differentiate between them biologically, we differentiate between them phenotypically, how the patient behaves. And so one of the big issues obviously is what's the underlying biology that makes somebody different, and that's the part that I don't fully understand.
But that's almost transparent to a payer, right? The payer has the problem of, I've got this diagnosis, and I think what I heard you say is that ICD-10 doesn't distinguish.
Correct, it does not.
It doesn't parse it out. With that book's about this thick. You would think that in a disease that has 1 million people in the United States, ICD-10 would have addressed that. Why didn't it? Why didn't it?
Backwards. I don't understand.
Do you know why?
They don't differentiate.
Well, I think but it is an opportunity, right, to move beyond where we are in terms of the specificity of coding, which we've seen, for many other parts of the body. So how do we evolve into the next version of an ICD that hopefully does capture different subtypes?